Hey y'all, it's me, Dr. Sameena Rahman, GynoGirl. Welcome back to another episode of GynoGirl TV. I'm Dr. Sameena Rahman, and today we're going to talk about the latest guidelines that came out of the American Urological Society last week about the genital urinary syndrome of menopause. This is huge. There are guidelines for this, which we've discussed on this platform many times. I'm going to tell you why this is important, so let's get at it. Hey y'all, it's me, Dr. Sameena Rahman, GynoGirl. Welcome back to another episode of GynoGirl TV, and I'm Dr. Sameena Rahman. I'm located in downtown Chicago. I have my own practice, and I'm recently going to be merging with a Ms. Medicine network of concierge doctors. So look forward to telling you guys more about that. I'm going to reduce the number of patients I'm seeing, and so we'll soon be sending out a huge mailing to over 4,500 patients, and I'm going to reduce it down to about 400 to 500 so that I can provide more individualized care and more specialized care and really just more nuanced care in a fashion that I am comfortable with and my patients will love. So looking forward for you guys to hear more about that. I also have a podcast, GynoGirl Presents Sex, Drugs, and Hormones. Remember, I am a gynecologist who's board certified, but I have a specialty in sexual medicine and menopause, and have been exclusively treating that for over a decade. And I've been an OBGYN for almost 20 years now, so that's a lot. Anyway, today I want to talk to you about the AUA guidelines that came out last week. If you are a clinician, listen up, this is huge. If you're a patient, you know that I've already been speaking about the genital urinary syndrome, menopause, vaginal dryness, how it's not just vaginal dryness, how it can kill you. I've been saying this for years. And we're gonna just talk about it a little bit more again, but just talking about the importance of why guidelines are so important, okay? So the American Urological Society is a huge organization of urologists around the country. Urologists have historically had many guidelines to helping the urologic surgeons kind of navigate genital urinary diseases, sexual diseases, sexual dysfunction, anything from around the prostate, all of that stuff. And there are guidelines for them so that they can keep evidence-based and really improve the quality of care. There's never been guidelines for anything related to female sexual medicine, so this is a huge win for us. The guidelines are very detailed. This has been a couple years in the making. I'm not a urologist, but I am on the ISWISH board of directors, so I helped to kind of like just put my stamp of approval on it, reviewing it, and was involved in that process peripherally. But I shout out to all the urologists that I am good friends with. I have two brothers that are urologists, but my good friend Rachel Rubin and Dr. Erwin Goldstein and all of these guys really pushed hard to get this information to the urologists around the world, really. But now there are some guidelines about it. And the reason it's so important is if you're not learning this in medical school, if you're not learning this in residency, and you're a busy clinician, you may not have time to read all the articles that are out that support the use of vaginal estrogen and pelvic floor therapy, which we're all going to talk about. And so you end up neglecting these patients who have such significant concerns in midlife and beyond. And at the end of the day, these patients don't get the help they needed. And at the end of the day, people not only have a terrible quality of life and a terrible sex life, but they die from these things. What's really impressive is there was a study that was presented at the AUA the last week of April, depending on when this goes live. In my previous videos about how vaginal estrogen is life-saving and all of these other things, and I talked about my own experiences and when before my mother-in-law passed away, how she had a UTI that took her into sepsis. This was years ago when I talked about this for the first time. And I said that if vaginal estrogen, and I say this in all my talks, that if genital urinary syndrome and menopause and the changes related to the lack of estrogen and androgens, right? Because we know that our vagina and vulva and clitoris and all the area below, as we say, all your essential organs and your genital urinary tract have estrogen receptors, and we know that declines in menopause. They also have androgen receptors, and that's oftentimes the missing piece for so many patients. And so if you're not getting them local testosterone or local estrogen, then they can still have persistent sexual pain. Just backtracking, the genital urinary syndrome menopause, which again I talked about in so many other videos, is chronic, persistent changes in the genitourinary tract related to hormone deficiency. And so that could be, again, the lack of estrogen, but also the lack of testosterone that happens over time. And so what happens to patients is that their vulva becomes smaller, so the labia can resorb and shrink away. The clitoris can become smaller. The vulvar vestibule. Remember my friendly vulva puppet here, where we talk about the vulvar anatomy that changes with these hormone deficiencies. We have the vulvar, the labia minora shrink, the clitoral hood. Clitoris can get phimosed, and the clitoral hood can get stuck here. You can get these changes in the vulvar vestibule at the opening from the inner labia minora to the hymen remnant. What happens to that area is with the deficiencies of androgen, which is testosterone, and estrogen, the tissue changes, it shrinks down. You lose elasticity because estrogen is so important for collagen, the production of collagen. The vaginal microbiome that I talk about a lot too changes, right? You go from an acidic pH that is full of lactobacillus that make lactic acid that keep it acidic to a more basic pH because, you don't have the vaginal estrogen that will feed the storage of glycogen in the vagina, right? And so then you don't get the lactic acid that builds up and all of the things that help the vaginal microbiome to stay acidic. And so when that changes and you get dysbiosis, where the microorganisms are not happy together, you can get some other microorganisms that can cause bacterial vaginosis, that can cause UTIs, right? Because also the urethra, where you pee from, has estrogen receptors, has testosterone receptors. And so when this area becomes less elastic and it becomes less blood flow here, it becomes red and angry. Here's a picture. It becomes red and angry and it becomes really prominent. And then at the same time, these bacteria can jump on into the urethra and cause a UTI, especially when you are still sexually active, which so many of my patients over the age of 55, my 60-year-olds, 70-year-olds, 80-year-olds are coming to me to get their vaginas fixed for sex, and we help them. But, they get the recurrent UTIs. And what happens to patients when they get a recurrent UTI in postmenopause? Many of them end up getting an infection that might go into their kidneys or their bloodstream, and then they get sepsis, and sepsis kills patients, right? So I've always said, if the genitourinary syndrome of menopause leads to recurrent UTIs, and vaginal estrogen can help, and vaginal estrogen reduces your risk of UTIs, and UTIs kill patients, then vaginal estrogen could save a life. And this has been something I've been saying for years. And now we have data to prove it. There was some data that was presented at the American Urological Society that looked at over $6 billion of healthcare dollars that were spent for admissions to hospitalizations from urinary tract infections, right? And what we know is when you use vaginal estrogen, you can get a 50% reduction, as well as vaginal DHEA. Remember, DHEA is a precursor to both estrogen and testosterone, and it can lead to better lubrication, and it can lead to more elasticity, and it can lead to less urinary tract infections by at least 50%. So vaginal estrogen, vaginal DHEA, boom, boom, can actually reduce your risk of getting a UTI. It doesn't necessarily eliminate it, but it will reduce it by 50%. So what they found in looking at the healthcare dollars that were spent, looking at the admissions to the hospitals, that if there's $6 billion healthcare dollars that are spent annually, but this was looking actually over a 2 or 3 year period of time. They looked at over 11 million patients, and then they stratified them into, this was over 3 years, and then they stratified them into ages and symptoms of UTIs and all that stuff. What they found is for the patients that were using vaginal estrogen, there was a 22% reduction in hospitalization, a 51% reduction in sepsis, and a 73% reduction in mortality. That means 73% of the time you can save lives. You will reduce mortality with the use of local vaginal estrogen. Okay? Huge. This is something we've predicted, but now we have data to prove it, and it's so nice and gratifying to see that. Okay, so that's the newest data there, but these guidelines are really important. The American Urological Association now has these guidelines based on evidence that was really studied and reviewed over the last few years that demonstrate that when people have the genitourinary syndrome of menopause, remember, it's not just vaginal dryness, it's not just vaginal irritation, it's not just, atrophic vagina. This is a condition and a syndrome that related to the deprivation of those hormones can cause sexual pain, it can cause pelvic floor dysfunction, and it can cause urinary frequency, urgency, you gotta go, stress incontinence, urinary incontinence, and from urge-related symptoms, as well as recurrent UTIs. And so we're treating these recurrent UTIs, and we end up having significant improvement in symptoms and a significant improvement in life expectancy. So it's really a big deal. We also say that when women get up in the middle of the night and they have to pee, and then they're in the dark and they trip on something, they might fall. If they break their hip, there's a 30% risk of mortality. So in many ways, if we can prevent some of these urinary symptoms and these urinary tract infections, we can actually not only improve quality of life, but actually save lives. And so for those of you who tell me that, you're practicing some sort of medicine that doesn't save lives anymore, it's not true. Actually, we are improving quality of lives and we are saving lives by using this. And so these guidelines that I'm going to link here really talk about the first line therapy for these symptoms. So when you have a patient in the office that has these symptoms, they should get screened for genital urinary syndrome menopause. You have to look for the findings of genital urinary syndrome menopause, and then you need to treat appropriately. First line treatment for this is either vaginal estrogen in the form of the pill that we talk about, like the Uvafem, Vagifem, the 10 microgram vaginal tablet, the Imvexi, which is the insert. It can mean 4 micrograms or 10 micrograms. 1 milligram of Premarin cream or the 0.1 of estradiol cream that you kind of get into the vagina, rub it on the vulvar vestibule. There's an estring that you can use that shouldn't be confused with Femring. Femring is for systemic absorption, meaning that we're trying to treat the vasomotor symptoms, the bones and all the things. So the estring will stay locally. It doesn't increase your blood levels above sort of postmenopausal baselines for the most part. And then there's intrarosa, which is vaginal DHEA. It's progesterone. Remember, within the cells of the vagina and the vulva, it converts that DHEA into estrogen and testosterone. So in my opinion, it's a superior drug because of that, because especially for patients with painful sex, there's a lot of testosterone receptors at the vulvar vestibule where you get that pain on initial penetration. And so these women truly benefit much more from this medication. And then you have the vaginal DHEA. For some patients, they don't want to put anything down there. Don't let me do it, doctor. I don't want to touch down there. They have a lot of shame and stigma still associated with it. What can I do? That's what they ask me. And we can give them ospemifene, which is an oral medication that works locally in the vagina. And it's a selective estrogen receptor modulator, just like tamoxifen, just like the medication that's in Duovi, the benzodoxifene. This is a medication that will give positive effect on the vulvovaginal tissue for estrogen, but not in any of the other places we don't want it. So that's ospemifene, and it's oral. You do have some systemic side effects from it. I talk about all these in detail in the other videos. And then we have to include pelvic floor physical therapy. I always say that, in this day and age, a lot of people are anxious. A lot of people are clenching. If you're not clenching your jaw and you're not clenching your pelvis, you're probably not paying attention. So with that clenching and the clenching from pain on initial insertion, the clenching from holding your bowels and bladder can cause the pelvic floor to become hypertonic, high tone, and basically the muscles can shorten and become weaker, and that contributes to more of the incontinence. So you have to have pelvic floor therapy alongside of that. Sometimes we use suppositories to help relax the muscles. Sometimes we use wands, we use pelvic trainers like dilators, all of the things. So those are all very important. So we have we're treating the hormonal deficiency, and then we're treating the muscles as well. And so that's all written in these guidelines. It talks about the safety and the efficacy in multiple patient populations. The key to understanding, because there was some confusion on Instagram recently that we're all talking about how there's no, systemic absorption. We're not saying that when you apply something in the vagina and we call it local, it does not mean that it is not systemically absorbed. So that is not true. What we're saying is that it is the route that we're doing it, right, locally. And there's a lot of different ways to get it through the vagina, right? You can get it in a ring, you can get it in a gel, you can get it in the insert, all the things. And this is, when things are absorbed through the vagina, it is dose dependent. And so, you can think about back in the day when we thought that we needed a ton of estrogen to prevent ovulation, and that's how birth control pills were initially thought of, back in the day. They were using 100 to 175 micrograms of estrogen to preventing ovulation and causing all these issues. we now know that, the progesterone that we're using is helping to prevent ovulation and the estrogen supplementing, but we only need anywhere from 10 to 30 micrograms. So we used to use 100 to 175. Now we're using 10 to 30. So the dose of things matter is my point. And so when you're absorbing stuff through the vagina, it's done in a dose-dependent way. So that means that we've kind of formulated the doses through these FDA-approved products so that we know that you might get an initial bump in the first couple days, but your long-term sort of serum levels or your blood levels of estradiol do not really go above what is considered in the postmenopausal range. And that is why it is considered safe for breast cancer survivors, for endometrial cancer survivors. It is considered safe for many patients who have history of DVTs and blood clots. It is considered safe for patients who have cardiovascular disease, for patients who otherwise you wouldn't necessarily want to give estrogen, right? This is also why it has a boxed warning on it still. So despite the fact that these formulations, which again, when we absorb things through the vagina and the skin, it is dose dependent. It really depends on the type of dosing that we're using. And when we have formulations that have been thoroughly studied through rigorous randomized controlled trials, and so these things have been studied and formulated so that your serum levels or your blood levels do not exceed what is in the postmenopausal range. And that is why it's safe for these patients. And so I think that is sometimes where the confusion is. And because when it comes to FDA boxed warnings, if it is estrogen as a whole gets the boxed warning, it doesn't account for, smaller doses, micro doses, local absorption that doesn't increase systemic levels above a baseline postmenopausal level. And so that's where the confusion is, because then a patient will read, hey, you know what? This can cause blood clots, cancers, it can cause all the things that at some point may have been associated with estrogen at systemically high levels. And so patients are dropping it. They don't want to do it. And so that's why we're trying to fight to get the box warning off of vaginal estrogens and these products, because again, they're dose dependent. And so these doses are safe and effective for basically all humans that have vaginas. And so I think that is one of the biggest things that this outline kind of reviews the literature on that and kind of breaks down the safety and efficacy of local vaginal estrogen in the doses that are FDA approved for the use of genital urinary syndrome menopause to keep the levels low systemically. So these are kind of the nuances that we have to deal with and talk about. And so at your visits, it is a nuanced approach because some people may not tolerate one. Some people might feel like cramps and other things from using it initially, and then it dissipates over time because, hey, your body's smelling estrogen for the first time. So you might actually, have something that feels systemic happen to you. And then usually it dissipates over time because the blood levels are not going to be sustained. And so I think those are very important things and nuances to remember. So this is the American Urological Association guidelines. The other thing it kind of talks about are like other therapies, use of lubricants and moisturizers, which we love. We love to use them. We consider them more like Band-Aids than anything else. So, moisturizers are great for twice a week. Hyaluronic acid-based moisturizers are wonderful to keep the vagina kind of moist and lubricated, and so you don't have all these other irritations or, feeling of like when you're wearing like some tight leggings and it feels very uncomfortable, you can actually reduce that friction, as well as lubricants that are used during intercourse, which so many of us love silicone-based lubricants if you're not using silicone-based products for, toys. But silicone-based lubricants last longer and they don't really affect the osmolality of the vagina, meaning that they don't cause like worsening dryness as some water-based lubricants do. So that's also discussed in these guidelines. And then energy-based treatments are also discussed in these guidelines, which are your YAG lasers, your CO2 lasers, your radiofrequency ablation. And basically the summary is that, this is obviously joint decision-making between the clinician and the patient, kind of navigating what might be in their best interest, that the data does not support that any of these modalities are superior to vaginal local estrogen therapy or vaginal local DHEA therapy. So that plus, your pelvic floor therapy, very important to work together. And so I think it's really important to, review those guidelines and showing that really lasers don't have much of a role here, except for some patients that really love them. And if that is the case, and they've used them in the past, and they don't want to deal with a lot of maintenance, right? Because genital urinary syndrome menopause is a chronic progressive condition. When you stop using your treatments, the condition comes back, and it comes back with a vengeance. So it's really difficult. And so it's like I tell my patients, if you're brushing your teeth, if you're washing your face at night, you're going to do something for your vagina. So that has to be a routine. And most people either do twice weekly intravaginal estrogen or daily DHEA, where if you have the ring, the estrogen, it works so that you can use it and leave it in for 3 months at a time. Remember the fem ring, which is systemic levels, so it gets your blood levels high. It's absorbed through the vagina, but it works for both local and systemic therapy, meaning that you can get treatment for that genital urinary syndrome menopause, but you also help your bones, and you also help, those vasomotor symptoms, hot flushes, night sweats, muscles, all the things. So it's actually kind of a twofer, but it's a little bit expensive, so that's why some people can't use it. But if someone have to have more of a low maintenance vagina and a low maintenance menopausal care, and they can afford it, or if their insurance covers it, we try to do the fem ring to treat the vaginal tissue. It doesn't always get to the vulvar tissue, so you still sometimes will need additional help if your symptoms are sexual pain. That's the one, I think, downside to it as well. But if you want, and you just have, maybe recurrent UTIs, or maybe it's something around just vaginal dryness, you use the fem ring, you leave it in for 3 months at a time. You take your progesterone if you have a uterus. You don't take your progesterone if you don't have a uterus, unless you had some other benefit from it. That's with the fem ring, remember, because it's systemic levels. With typical sort of vaginal estrogens, you don't need to take progesterone if you're just treating genital urinary syndrome menopause. Because again, over time, the systemic levels are not above the baseline of postmenopause. And so for some patients, they love it. But again, my point is that it's a chronic progressive condition. So you have to continue to work at it. Backtracking to the lasers and the YAG and the radio-based frequency therapies, the American Urological Society, after reviewing the data, again, really demonstrate that we have to really push to use, these FDA-approved products, but if patients really want to, it's joint decision-making. And the best data we have is with the CO2 carbon dioxide laser, and most of the data is around the Mona Lisa Touch. For those of us that initially, like I said, I've been treating GSM for the last 11 years in my office, and so initially I silly bought the Mona Lisa Touch for my patients, thinking that it would be a benefit, because at that time nobody was giving it to patients that had those other cardiovascular risk and cancers and all those other things. And so for some patients, they really love it and they work, and so they use it every 6 weeks for a total of 3 treatments, and then they'll get a maintenance treatment. But I would say if patients really want that therapy, which is not covered by insurance and it is out-of-pocket expense, they should still, have some use of vaginal moisturizers, lubricants, and vaginal estrogen in between. I thought it was a good time to bring up this exciting data that really does demonstrate what so many of us have been saying for so long, that the use of local vaginal estrogen can save lives in postmenopausal women. So that's very big. And then I think the other thing is that we have these important guidelines through the American Urological Association that any clinician can access now, so that people who have graduated beyond a time when this was not discussed, and they're not savvy on the internet, and they're not reading articles because they see 40 patients a day, they can quickly go to these guidelines and say, you know what, I don't know how to treat this, but this is a step-by-step approach on how I can help my patients. And so that to me is revolutionary, because again, if you're practicing in small town USA or a different area that doesn't have a lot of specialists and you don't have access to care, now any clinician can access this and really help you navigate your concerns. So tell your clinicians about it if you're a patient. Clinicians, here's the link in the summary down here. And let's do it, guys. Let's start helping patients to not suffer through menopause with genital urinary syndrome menopause. It's not just vaginal dryness. I'll say it again and again. It's preventing recurrent UTIs. It's saving lives. It's improving the sex span of women across the world, and men, if they're having sex with men, and other women if they're not. So, there's so much we can do here to better care. And so please look this up, talk about it, scream it from the mountaintops. This is a very important, and check out my other videos if you want more details on how I prescribe things. But I think this was worth, discussing again, because We can't say it enough. Thanks for joining me today on GynoGirl TV. Please join me on my podcast too, GynoGirl Presents Sex, Drugs, and Hormones. I'm Dr. Sameena Rahman. I'm here to educate so you can advocate for yourself. And please join me on my next episode. Thanks so much.